end there. And I know we've heard from some developers during the day, but I'm interested to know your reflections, having heard some of the speakers.
So, hi, I'm Nicola Tiffany, and I'm Managing Director of a digital agency called HMA. And we specialise in the design, development and marketing of health, science and tech-related products and services. So I'm here actually representing a charity called STEM4, which is a small teenage mental health charity based in Wimbledon. And we were, or are, their tech partner for the development of 2 mental health apps. One called Calm Harm, which is an app to help teenagers manage the urge to self-harm. And that was a result of an NHS England digital development lab, which was run by the lovely Habitat. And we worked with them to develop the app, which has now had over 870,000 downloads globally. It has an efficacy rating of 93%, so 93% of users have reported that the activities within the app have helped them reduce the urge to self-harm. And we have an active user base within those number of downloads of around 20 to 25% every month. As a result of that, we got some comic relief funding to build Clear Fear, which is an app to help teenagers manage anxiety, and that was launched in December. And I think in terms of today, it's basically echoed all the processes that we went through to create both of those apps, which is really positive to hear. We worked with users on a regular basis to not only inform the kind of functionality, but the teenagers that we worked with also helped to design Calm Harm. The avatars that you can use throughout the app, and they were really integral to the actual success of the product as well. So actually hearing that is something that everybody is valuing now within the digital health space is a really positive step for me.
Thank you very much, Nick. That's really helpful. Josephine, you've been instrumental in bringing this meeting together, so I'm very interested to hear from a mental health foundation perspective what your reflections are and how you feel.
Yeah,
forward.
Yeah, great. I hope everyone can hear me. I'm doing between 2 mics, so I'm sure it's fine. Just to be sure. Thank you very much for introducing me. And also everyone, thank you very much for being here. I've been a bit more involved in the background in terms of organizing today, and have been working on the eMEN project for 3 years now. So it's been quite a journey in terms of digital mental health and where we are now. And so one of the things that we're doing is we're setting up a randomized controlled trial looking at the prevention of depression in Manchester. We've done a large-scale survey of GPs to assess what their attitudes are towards implementation of digital mental health for depression. We're working on a lot of other surveys, and I guess my reflections on today, and I really tried to prepare for today in terms of for today's kind of panel discussion and thinking about co-production, and I kind of came from it in 2 angles. So one is, how do we co-produce? I think what really comes out to me, having worked in this field for some time now, is we have to have equality. So I guess I really reflected on the kind of comment by Chris, which was that we shouldn't do kind of prefab co-production. We should just really start with what do people want. But I also know that's quite difficult to do. When you have a project, you have to have your deliverables, you're running something, and you have to do something at the end of it, or you're coming into something with an idea. So I think it's kind of balancing that a little bit, and those tensions as well. And the other thing I reflect on quite a lot is like, how do we engage people who are seldomly engaged, and making sure that what we're doing with digital is not increasing the digital divide, but actually engaging people with digital, and making sure that we reach seldomly engaged groups and that they have access to digital interventions that work with. So, and then I come from it from a more researchy perspective, where I'm thinking, okay, we're talking about digital, but what is digital? What is it? You know, it's so granular, and it depends on so many different things that I think when we talk about digital, it's also helpful to have really broad discussions, but also be, and at one point get quite specific as to, you know, what are we offering to whom, when. So for example, digital for prevention, it's often, I guess, potentially apps or, you know, online forum. But it's good to be specific about that and then think about how can we improve that rather than talk about digital as an umbrella term. And I'm also quite interested in outcomes. So, you know, what are we measuring? Are we measuring uptake, or are we interested in evaluating the positives and the negatives from digital? And I think it's good to look at the good side, so doing kind of randomized control trials and noting when there are no effects, but also maybe trying to measure, you know, what are harmful effects, because it is important to think through, you know, why something isn't working for someone, and not just looking at, when you look at a study, thinking, oh, that person didn't engage, but actually why did that person not engage with the intervention? Why did they not continue? Because that's a big issue with digital trials, is that there's often not a lot of adherence with the intervention. So that's me. I've also got a bit of a reflection on funding models, but I'll leave that.
We can come back to that. Yeah. I'll give you a question on that later on. Okay. So that leads nicely into Diane. What are your reflections from an academic standpoint, Diane?
Okay. First of all, I'm Diane Pennington. I'm a senior lecturer in information science at the University of Strathclyde. If you can't tell by my accent, I'm not Glaswegian. It's been really interesting to hear all these different perspectives today from the different sectors and so on. I think that's really been a strong point of the day. It's been really, really nice to hear. I think one thing that, as somebody who does research, funded research currently, both in youth self-harm and people living with dementia, so looking at sort of two ends of the spectrum in terms of the lifespan and how we access information, that's what I'm really interested in as an information scientist, is whether or not it's digital, can people use it? First of all, most of all, can they find it? We could make the best app, control trial to death out of the world, but if they don't know where it is or how to use it, it doesn't matter. And so how do we find these things? How do we help them find these things? How do we get them to the right resources so that they're not finding the things that are not useful, not usable, negative, too complex? And how do we work together with them? So working directly with people with dementia and service providers and young people in my respective projects, what I keep hearing over and over again is that they just want to be heard, and they don't feel that a lot of our services reflect that. That, you know, the person with dementia just wants to find the right bus to go into town to get a cup of coffee, and it's too hard to do that because the bus schedules are too hard to read. That right there is a technical problem. So not everything that we need to work on is digital. It's also really about the nature of the information and how we present these things. Hopefully it's digital in some cases. It's in some cases the best way to do it. I think saying to tell young people don't use this, it's bad, it's not going to do anything because they're going to use it anyway. But we do have a responsibility to maybe help technology providers as well as young people and everyone involved find better resources. And, you know, it's not necessarily up to us to decide what is better. Talking to a peer can be just as good as, you know, having some psychiatrist tell you how you should be feeling. Those are different types of information, so we have to be sensitive to those contexts and what is best for that person at that time. That's kind of what I've been thinking about throughout the day.
That's really helpful. Thank you very much, Diane. And last but very definitely not least, an NHS perspective, Divya. Thank you very much.
Thank you. Good afternoon. I'm afraid I wasn't here earlier in the day, so please, I guess, keen to get your feedback on if I'm missing something when I give some of my reflections on the question that we were asked to think about. So I think from NHS, so myself, I'm Divya. I work in the mental health policy team at NHS England, and I'm the program lead for the infrastructure program. What that actually means is that in our policy team, we have colleagues that work on CYP-related mental health services, adult services. Where I sit is a cross-cutting function, which means that we support issues around data, around measurement, around digital solutions, around measuring outcomes. So it spans the breadth of what we're trying to do in delivery of the 5-year view. And as you may be aware, the long-term plan vision is about taking that a step forward and how to really expand access and delivery to services across the country. So I think the issue around improving access from our perspective and addressing issues around co-production is a really fundamental part of how we try to take the LTP, which is the acronym for the long-term plan, forward. And from our engagement so far, where policy teams have talked to service users and what they think would actually work in their settings, it's been really helpful. But I think the two key themes that come up with respect to digital is around choice, and it's also around trust. I think these are two quite fundamental bits, because I think, as everyone's talking about, there's different approaches, and I think the fact that you're being offered a choice is actually quite important, whether that's up to you whether you want to take that opportunity or not, whether it's around self-management, whether it's about in-between treatments of care, whether it's about helping support a country that you're currently on. And it's also about this issue around trust, which is, I don't want to then be left having a digital solution where I feel like I need to speak to someone face-to-face. And I think it's about respecting those boundaries that service users might have and trying to figure out what actually works for them and for the treatment path that actually would work for them. I think the other part for us is around the co-production is really a part of, I think, improving what the digital system can look like for mental health services, but it's really around making it a continuous part of how this can improve, just how it should improve, and making it agile. I think it's not around, we get some feedback and then we're going to go ahead. It's about, I think, from a policy perspective, it's this feedback and monitoring that kind of tends to happen anyway, that should happen. And I think we face a big challenge because there's a lot that can be done in the digital world, not only in mental health, but across, I think, public sector services. And I think there's very key challenges for us here. I think the next bit, I think it's really quite important to us, is that we know locally there's lots of trials happening. So for instance, we have funding put forward to mental health trusts that are in some ways going to take the digital transformation forward, that are called Global Digital Exemplars. And some of them are trialing apps in particular. Mercy Care is looking at how to use an app to help predict suicide and trying to see how that can actually work for their service users. So what we're trying to do is understand how these things are working in local areas. We're very keen to hear from your perspectives. If you are aware of anything like this, we'd like to collect that information, because we think the national offer needs to be drawing on these locally led initiatives. I think the other one to really point out is there was a pilot project that's still ongoing, but one was particularly run in Islington CCG, where they actually tried to look at what mental health apps might be useful and supportive for young people. And what they found through that engagement was really around having digital champions in these local organizations made quite a big difference to service users in that area to figure out what might work for them. Do they actually want to use an app? Do they have a choice? And would that be helpful in between treatment when they see another practitioner or not, or whether they decide, actually, I think I can use this app for the meantime, and then I'll decide whether or not I want to come and present myself to the service. So I think these learnings for us are actually quite important to see what actually can work in different settings, and really keen to hear your feedback on this as we go forward.
That's really helpful. Thank you very much, Livia. So we've got probably 20 to 25 minutes now, I think, where I'd really like to open up to the floor, having heard the panel's own sort of background and thoughts about the day and what we've covered so far, and actually building on the discussion we just had in the previous session. I'd like to open the floor to questions so that we can have a more open discussion, and I'm very happy to sort of think about themes. Obviously one that particularly springs to mind is Josephine's one is around research and research funding and research strategy, but I'd like to open to the floor first of all. Up at the back there on the left.
Hi, following on from what Diane said about working with people with dementia and working with the young people you were describing, there seems to be a little bit of a hole in what people have been talking about today in how and whether people in society who might not be able to so easily either access technology or so easily read are they being included in trials, or are they being included in the research that's going on about how useful the apps are? Because I was talking to someone in the break about children with learning disabilities and where do they fit in with this, and I myself work for a charity with older people, and I was thinking, where do they fit in with this if they, as many of them are, they're not keen on using mobile phones, say. That was a big question for me throughout the day.
Okay, thank you. So I'm wondering, firstly, if our sort of research members would like to address this, but I can see also that perhaps Divya would like to come back on as well. So Diane, first of all, are you, what's your view about this? One of the critical issues here was about access and equity and enabling the co-production, you know, for everybody.
That is absolutely essential, and I can say that as a researcher and a reviewer and a journal editor, that frequently we grab a convenient sample, right? So university students are the best tested people in the world because they're around, they're in the classes, they're easy to get to. What we find with working with the groups that we work with is that they are difficult to access. Ethics is very difficult at times. We just went through one online survey that we're about to roll out with for young people who might be in self-harming conditions. Ethics was very difficult. People with dementia, they can't really give consent in some cases, depending on how far their dementia is advanced. So that's also an issue. But they are the ones that are not being looked at the most, so that we might have something that's perfectly made for an 18-year-old first-year undergrad, but you know, whether or not that's appropriate for everyone. And in a lot of my work, it involves knowledge exchange research, where we do go out into their communities. We've been doing a series of co-design workshops for our self-harm project, and at a workshop we had in Edinburgh a few months ago, we had a group of young people come down from a group of young people with autism from Aberdeen, who came down, and we offered to pay their travel because they wanted to come, because they wanted to make sure that as they feel like they are pretty strongly represented in sort of a self-harm group, if you want to say that they don't feel like that their needs are being met. And they came down really wanting to be involved in the research because they wanted to have a chance to have their input, to have something that works for them. And you know, how often would we recruit something like that to just go off and say, well, you know, here's people with autism, here's their moms are coming down with them. That's a very different thing. And then to have them sit down at the table with the people from the NHS and service providers and other places, it's a very, very different way of looking at things that I think we exclude far too easily because it's too much work sometimes.
Mm. And there's a question there about whether or not we actually target specific groups and really really enable sort of access for one group or another one population, or whether we actually just don't target specific groups but ensure that we have good coverage across the board, but make it available to everybody. And you know, I'm interested in views of the rest of the panel around whether or not, you know, one strategy is better than the other. Josephine, I don't know.
Yeah, I mean, I think it's a really, really good point. I think we should. I mean, I know it can be difficult, but I think it's just we need to do more of it. But it also needs to be reflected in, you know, for example, journals and you know, sample sizes, for example, and that's a huge thing. And I think it's just. And funders may be putting emphasis on groups that are seldomly engaged in research, that are more difficult to engage with that. I think that's where the emphasis should almost be on, some kind of not thinking. And also, I mean, we did a systematic review looking at approaches that work for prevention in young adults, and what we found was all studies, all randomized controlled trials were done in university students.
Mm-hmm.
So. Yeah, so that was one of the points that we really hope to take forward also at the Mental Health Foundation, in terms of how do we change that and how do we influence that further.
Nicola, you're a developer. I mean, how do you negotiate this if you're doing it in an evaluative context?
Yeah, so I mean, I think I can't speak from a research perspective, but certainly we act as the design and development partner on a lot of academic digital health research projects, and from experience we've engaged with a lot of vulnerable groups, such as people living with dementia or learning disabilities. And there's no doubt about it that it is a challenging environment to be in terms of getting information out of them, but actually the interesting part of user experience and user design and looking at that kind of cognitive ability versus the tech that they're wanting to use, and how that might actually change people living with dementia as their cognitive impairment gets more progressive, then actually how does the user interface change to adapt to that and make sure that everything is personalised, because I think everybody has said it today, there is no one size fits all. So building personalisation techniques into the tech to help with that testing and research process will ultimately deliver the best results.
Brilliant, thank you.
Oh, just to quickly add, I mean, I think a piece of work that was done by another national team at the NHS looked at how, for instance, the NHS.uk website has been updated, and that was around making it accessible. Obviously, there was an issue around digital inclusion, and that national team actually did a discovery piece of work where they tried to actually get the vulnerable groups that you quite point out to, and to actually have them involved in seeing, can they understand the website? If they actually want to self-refer to service, would they know how to do it, and what was difficult? And that's actually been fed back, and now that's actually been updated to see how they can make that information a bit more accessible. So completely agree that I think there's different approaches that need to be done to be able to get that information as part of it. The other point that was really quite useful when we went to one service user event among perinatal service users, and they said that quite often so many people that come to these events are quite engaged. So how to get the ones that would like to be here to be part of that discussion, but cannot, maybe for work reasons, family reasons, can't actually be part of that conversation. I think that's also thinking about how do you put the information in different ways.
I had a question just up at the back, right by the wall. I don't know if you still want to. Well, yes, that's the person, and then I'll come down to you next.
Thank you, I'm Christine Burke. I work for the Mental Health Foundation, and thank you, Margaret, for remembering our conversation at lunchtime. I think co-production, particularly including those at the margins, can't be left as an excuse. It has to be done proactively, and we need to find ways to reach to those that are marginalised, those that are poor, those that are not engaging, because otherwise we are missing a whole population, and prevention has to be at the heart of reaching them. So co-production has to be with them, with everyone in mind, and not just as an excuse. Just like Chris said, we need to make sure that we engage with people from the beginning, including people with learning disabilities.
That's a helpful comment, thank you. We had a question just down here. Sorry to make you run around, Jade. Oh, okay, someone else got there first, thank you.
Hi, my name is Bo Chapman from Digital Arts Organisation. I'm just interested, after the APBG report last year, which overwhelmingly, if I can say, proved that arts actually improves health and well-being, why there hasn't been more exploration of the creative potential of technology?
I'm not sure that we're saying that there hasn't been more exploration. I don't think we've potentially covered it today. Is anybody from the speakers earlier, have you got any thoughts about that? Yes, Chris, I wondered if you would. Do you want to?
Yeah. Sorry, it's karaoke time. The foundation has an ongoing interest in the arts and mental health. We host the Scottish Mental Health Arts Festival, which is one of the biggest social justice festivals in the world, and the potential for digital in creativity is something which is one of the very strong positive mental health aspects of digital technology. So if you look at some of the work that's been done, for example, in the now deceased Young and Well Collaborative Research Centre in Australia, the work that Colin did on very good systematic review of the positive aspects of social media use, one of the biggest things they picked up was the potential for young people to collaborate and create digitally using social media and digital tools. And we see in terms of the way people can curate and share their narrative and make sense of their own journeys and stories, creativity is massively important to that. And as an organisation that values the arts and mental health, it's something that we are particularly keen on, and something which is desperately important that we see more of in the arts space and in the mental health space.
I think I just meant as a means of engaging.
Definitely.
And reaching people through creative activities. Getting in sideways.
I think it's fair that that work is ongoing, and we probably just haven't managed to cover it today. But certainly, Chris is aware of this, and I know we have some similar things around arts and creativity and co-design and co-production in the University of York. So I'm sure it's widespread across many universities. I don't know if anybody on the panel is aware of others, but yes, we're not dismissing it. Very important. So. Yes, question at the back. I think that might be Anita. Yes, and then I'll come to you here.
Hi, Anita Patel. I'm a health economist. So I was formerly an academic researcher of a couple of decades and a trialist. So I understand all of Simon's points from this morning about the necessity for high quality research evidence before we implement these digital technologies. Josephine was going to raise the point about the funding models. I don't know whether it was going to the public sector side of investment in all of this. It feels like the whole kind of evidence generation thing is a runaway train in a sense, because we haven't got frameworks in place to define what's acceptable beyond RCTs, and I think there's a recognition in this room that we need something other than RCTs. So I just wonder what people's thoughts are about this risk that we're taking, that we're already kind of investing in public monies without knowing the full effectiveness and cost effectiveness of these multiple interventions out there now.
I've some thoughts myself, but Josephine, I really ought to come to you because I know you've raised this already.
Yeah, I think that's a really, really good point. I think, and it's also kind of what do you do when things are being implemented, regardless, or there's a new initiative, and it's almost it's going ahead with or without an RCT attached to it, and sometimes that does happen in spaces. And I think it's so important to try. I mean, I try and do that as much as I can as a researcher, to try and say it is so important to have robust evaluation as part of it. Do a feasibility study and then maybe see whether you can take it forward in an RCT, and then preferably a pragmatic one, so one that doesn't add, one that maybe potentially can use routinely collected data already that's in the system that you could maybe use as outcomes, rather than doing more assessments, which of course takes time and costs more money as well. So that's where I'm coming from, and I don't necessarily have a solution to that. I think I'm just trying to kind of keep on sharing that message that it's so important, because the value of doing evaluation alongside implementation, or at least preferably before implementation, is that you can already kind of, it highlights quite a lot of things that might come up as you implement already. So it's not only helping the evidence base, but it's also helping you to improve the products or the intervention that you're delivering. You can kind of make that a learning process. And stop talking a second. I think the work from Professor David Moore is quite interesting from the States, where he talks about kind of continuous evaluation techniques, and I've been following that for some time, and I think maybe that's where we should focus on, trying to kind of pragmatically evaluate things as they're being implemented.
Yeah, just a very, very important point. Completely agree. I think from the national perspective, what has just recently been released is an evidence framework to address and think about how do we unpack evidence and what are the thresholds and requirements. This is very different, what's now on the NICE website, from what evidence and requirement thresholds we need, say, for medicines and for other digital and for other medical devices. So that is now out there. I think it's really important that NICE is wanting feedback on it. It'd be really great for the research and those of you out there that are interested to feedback into that content, feedback into that document, to please take this opportunity. The other part that is also available is something called a digital assessment questionnaire, which is about setting up some standards of what developers should think about if they actually want to submit, for instance, an app to the NHS. And I think my comment around co-production and the impact on sort of feedback and monitoring to be ongoing is really to get at the fact that it's about not only informing upstream, so designers to develop what they can do, but it's also about downstream to inform commissioners and what they think they would want to actually commission and put public funds towards as well.
Thank you very much, Diane.
It's interesting because I work obviously with people in healthcare all the time, but that's not my background, and I'm really more of a social scientist than anything else. I wasn't even trained in RCTs in school because we just don't use them. We use completely different sets of methods that, test an RCT is what you do when you test a new medication. It's not what you do when you test a website. So for us, it doesn't really make any sense to do it that way, and I didn't even learn about it until I started collaborating with health people, because I won't get that much money from the SRC to do a trial. If I get a couple £100,000 for 5 years, so we don't do it that way, and we certainly wouldn't have the same results, possibly, but we're also looking at different variables and different factors and doing smaller sets of iterative design and working with smaller groups of people more in depth. So it is a very different approach to research, but I still couldn't manage RCT to this day if I had to.
Yeah, I think from Carnham's perspective, we haven't been through a thorough academic evaluation of that product yet, although it is in discussion. But we did start with an effectiveness model for that app and wanting to understand how people were using it and how we could use that information to further develop the app, just as you suggested. But what was really important for us when looking at that evaluation model and the data that we would collect was that actually we wanted to be at the complete opposite end of the spectrum to the Cambridge Analyticas of this world. So we built an anonymised data model whereby we could get demographic data, but it wasn't about people's personal information. We don't need somebody's email address to know whether they're finding the app useful. So that kind of data design at the start of a project is really important to understand the outcomes further down the line, even if you haven't started thinking about an evaluation when you've launched the product.
Thank you very much. I'm going to slightly abuse my position and just sort of do a round-off comment because I feel like I need to some extent, just sort of put up a hand for the important role of good evidence and good quality evidence. And I've been reflecting over the course of this afternoon's talks that we have certainly travelled a lot over the last 20 years. I think we've maybe gone slightly round and round in circles. I'm not convinced we've got very far, but I think we have learned a lot. And I think that the critical point that's come out of this afternoon for me is that actually one of the reasons we haven't got as far as we might have done is we haven't really joined forces with the people who are using and implementing these things as we go along. So we haven't done proper co-design and co-production. And I think if we kind of rethink that space a little bit in an evaluative context and actually start designing and developing things jointly that are likely to be fit for purpose and driven by user needs and priorities, we'll kind of move away from this, sort of fast-paced development, getting a new app just because you can, or getting a new piece of tech just because it's available or because it's commercially viable for a particular company, and actually start developing things that are really valuable, can be evaluated along the way, and then can be submitted to a more robust sort of research evaluation. So I don't think we should throw the baby out with the bathwater. I don't think we should let go of trials or evidence in this, but I think there are different types of evidence that contribute to our knowledge base about the safety and effectiveness of these interventions for different types of people, and we must keep in mind that that is important. So over to our next question, which is over here.
Yes, my name is Johan Vleiter. I work for the Art Foundation in the Netherlands. We're also involved in the eMEN project. I would like to thank Mental Health Foundation for organizing this seminar. We are organizing similar events around Northwest Europe because the European member states have the similar problems when it comes to the implementation of e-mental health. We have received funding from the EU because the European Commission says this is a problem for the whole of the European Union. And we need to tackle these issues, these challenges jointly. My question would be for the panel, what would be the three main implementation barriers when it comes to e-mental health? Because today I've heard great presentations, but often focus on product development and co-creation. Are there other issues besides that and the RCT mentioned? And we make a distinction in the project between wellness, which we're not focusing on, and professional e-mental health. Maybe to add, in the Netherlands, most treatment centers, they offer e-mental health, but it's not used efficiently. Not even 15% on average of all treatment is done with e-mental health. And up till now, it's costing money instead of making treatment more efficient. So it's on top of current treatment. Technology has been here for 15 years or more, but it seems to be very disruptive and difficult to integrate in the care pathways we have.
So I'm not going to ask everybody for their three top, but barriers to implementation, if we can think about those.
I guess one of the other ones, in addition to what already has been highlighted, is around whatever feedback we want to get that would inform, say, improving whatever digital technology is out there, how do we want to actually collect that information? And there is a challenge and a question on, should this be open? I mean, for instance, when you look at medicines, and if there is the phase 4 part of medicines is that there's a pharmacovigilance element to that, which then gets reported up to MHRA. Should there be something like an open platform where you can share this anonymized information around whatever tool that is? Because as we know, they're on the app stores. We're talking about an app. People can access them anywhere. So should we think about something that's crossing country boundaries here, that's being actually not having a boundary in that sense, but it being with one country or another? But should there be some way of sharing this information that could be quite useful? Obviously, there is people, but should there be something thinking about how we collect this information in a different fashion than how we've been currently been doing it?
Josephine?
Yeah, I mean, I was thinking about this a little bit. I think one of the things is so I heard it's more costly to have digital in the Dutch healthcare system. So it's more costly to actually operate jointly rather than having face-to-face contact. If I'm correct in that.
It's face-to-face, and on top of that, digital health.
Yeah, so that's an extra cost.
Yeah, and you get a little bit more extra money from the insurance company if you use eMental Health.
Yeah, yeah.
But
So I guess it's interesting. I guess I wonder why. You know, why is that the case? Why would it be so costly? What can you do about this? One of the things that we found in our survey, in the paper that we just published this year was, or last year, it was about staff and what it was on GPs and kind of assessing their attitudes towards digital mental health. And what we felt was what we found was there was quite a bit of a need for more understanding around what digital can do for whom. So I would think that would be a potential barrier if you're thinking about kind of clinical implementation then that would be one of the things I would try and look at. And also I really like Diane's point around where do people go and what is what is valuable. And I know that there's been a lot of work done on that, and we've heard about good thinking, and that's really good model. I think it's just again reflecting: are we really then reaching, still engaging the seldomly engaged groups, and are they able to find that as well? So I would see that as another barrier towards implementation.
Diane, Nicole, any reflections on this?
I think there are technical barriers, but I think ones that might be harder to overcome are not technical. I think, first of all, the stigma issue, right? That's one of the big barriers still that we don't know how to overcome. I would say, though, that there's been a lot of grassroots campaigns just in very recent times with young people trying to overcome stigma and make it okay to talk about it. And I think you might find that if you went further into some of the youth communities, they find it better to talk about it now than maybe we did when we were young people, earlier on, that it's becoming more open now than it used to be. So I think that's one positive change. So I think stigma is one, and I think another one is just knowing what's there. A lot of people don't know what's there, and so how do we get the word out that there are things that are available? So we've heard about all these different apps and things, and okay, so like you said, where do we find them? How do we get people to them? And that's not really technology itself, so that's just more about awareness and education more than anything else. That's what I've heard a lot. I did focus groups with young men recently who were giving some feedback on a particular resource, and they said, this is great. If I knew about it, I would have told my friend about it when I knew this friend that was having problems. So the other thing is that they don't use the same language that we use. So that's why NHS calls it depression. They call it life sucks, right? And so those kinds of search terms in Google or the App Store won't get them to the things that we consider to be professional and effective and evidence-based, because we don't necessarily put those more common terms into things that we think are clinically effective and so on, because there's just two different sets of languages. When I watch people Google for things, they type in things like, my life sucks and I want to die. That's not going to get them to the NHS. It's going to get them to things that we might not want them to get to. So how do we work around that? How do we get those kinds of things into the resources that are effective to make sure that we're speaking in their terms, so that they actually find it and not expect them to speak a language that they don't know yet.
Anything from our speakers earlier on? Because I wondered if Victoria might want
Do you want me to?
Yes, if you wouldn't mind, thank you, unless there's a mic.
From an NHS, well, from a healthcare perspective, there are tons of barriers, and the NIA, National Improvement Accelerator, Innovation, I always get it mixed up, Innovation Accelerator, wrote a really good report about why technology doesn't get adopted in the NHS, and it uses case studies to give advice about how to get adoption from the adopter side. So it's a really good resource. Another really good resource is the NAS framework, which is an empirically based framework developed by Trish Greenhouse. She's an academic at Oxford University. And it's a 7-point framework based on a whole load of research she did around why technology doesn't get adopted, and she's developing a framework that we're working with her on to, or applying that framework to a practice setting. Out of those 7 domains, only one is technology. All the rest are around leadership, culture, systems, attitudes, beliefs, and the need to redesign pathways and workflows. So if you're looking to, as you know, deploy something within a service setting, if you add one iota of work to somebody's workload, it's not going to happen. So digital needs to be an enabler of transforming, improving services, rather than just being sort of thrown in or plonked on top, I guess. So there's some really good resources out there and some good learning from the centre and from academia about how you recognise some of the barriers and how you then mitigate some of the risks to implementation and adoption. But they're very well rehearsed, I'd say.
Brilliant. Yeah. Thank you very much, Victoria. In the interest of time, I think I'm going to draw this to a close unless Andre's got any questions that are coming from beyond the room. So I think at this point we'll wrap up and then hand over to you for some final reflections on the day. Please join me in thanking our very excellent panelists this afternoon.